Do the guidelines need an update? That's my disclosures. Now, and I would like to begin with a recommendation that has been highlighted in the ESC guidelines, that opportunistic screening for atrial fibrillation in older populations age 65 has been highlighted as a Class 1 recommendation. However, since then, the tools for screening atrial fibrillation have developed from just taking a pulse or taking an occasional ECG or perhaps performing a Holter monitor to a more smart technology. And here is one of the examples. Now you can use your iPhone, and probably a newly released iPhone 6 should have this equipment, this technology already integrated, rather have it attached or downloaded on the phone. So one can record their rhythm using a smartphone and therefore diagnose or self-diagnose with atrial fibrillation if this takes place. In the meta-analysis of studies that looked at opportunistic screening for atrial fibrillation in the populations without AF, it has been shown that these tools would help to identify additional 1.4% of patients over 65 years of age, high risk for stroke, who did not know that they might have atrial fibrillation. In the CRYSTAL-AF, the study in the cryptogenic stroke and underlying AF, that's the acronym, patients were randomized to receive either an implantable recorder, Reveal Medtronic device in this case, or just being monitored routinely with a standard 12-lead ECGs and 24-hour Holters. These patients all had a history of cryptogenic stroke or transient ischemic attack within the previous 90 days, and this was confirmed on the MRI or CT scans. So we see that with with internal loop recorder monitor Reveal, the rate of detection of atrial fibrillation that has been unrecognized increased. At 6 months it was 9% in the interventional group versus 1.4% in the standard care group, 12.4% at 12 months versus 2%, and 36 months 30%, 1/3 of patients with implantable loop recorders had been diagnosed with atrial fibrillation, as opposed to just 3% of those who received usual care. So we are facing a new era of screening for atrial fibrillation in the general population and in specific clinical settings, such as unexplained stroke. A number of imaging techniques have emerged that would help to further refine risk stratification in atrial fibrillation. And I would like to share with you a couple of examples. This is an interesting test that detection of cerebral microbleeds that could be seen as very tiny areas that you can see here pointed out with the green arrows, these small black dots that are asymptomatic cerebral microbleeds. And in patients, if you look on the right side of this slide, you'll see that those patients in whom microbleeds were detected on the cerebral MRI, these patients had almost 10 times higher risk of developing intracranial hemorrhage during subsequent follow-up. Then imaging of the left atrium using MRI technique and quantification of left atrial fibrosis may lead to improvement in risk stratification for stroke. In this particular study, patients were otherwise with similar characteristics, but those who had significant atrial fibrosis on the MRI scans were more likely to experience stroke, and many of these patients had atrial fibrillation ablation. Now, a number of biomarkers have emerged, and this is just some of them. I'm not going to list each of those, but I will take you through a couple of things. Now, troponin I and NT-proBNP have been highlighted as biomarkers of risk of stroke in their biomarker sub-studies of several clinical trials on new oral anticoagulants. This is an example from the RELY study showing this very tall red bar on the left. That's a combination of the highest quartiles for troponin and NT-proBNP, which significantly increases the risk of stroke. In the Aristotle trial, they looked at NT-proBNP, and you can see here that independently of treatment strategy, higher quartiles of NT-proBNP were associated with a significantly increased primary endpoint of stroke and systemic embolism, as well as cardiac death, as shown here by the orange lines on top. And the blue line at the bottom is patients with the lowest quartile of this parameter. This led investigators to seek an alternative risk prediction scores. We know that we're all using CHADS-VASC, and sometimes some other investigators developed in North America the ATRIA score for stroke prediction. This is a very recently presented ABC risk score for major bleeding that includes age, biomarkers, and C, current disease, ABC. This was derived and tested on the Aristotle population, and they found that compared with the has-bled risk score that is advocated in the EEC guidelines, the C statistics for the ABC score was significantly better, 0.68. It's much better than 0.59. Anything when we talk about C statistics which says 0.5, that's really not a good indicator. The net reclassification index, it's meaning that when patients were retested using the ABC score and deemed either high or low risk of bleeding, was 25%. 1/4 of a patient were qualified as having different risk of stroke. Now we are moving into a totally new era when it comes to anticoagulation for atrial fibrillation. This is a meta-analysis of 4 large randomized trials that you all are familiar with. And I don't want to dwell on specific trials, but I would like to emphasize that as a class, these agents outperformed warfarin in terms of reduction of a very serious complications such as hemorrhagic stroke and intracranial hemorrhage, and also there was a trend towards improved all-cause mortality with new oral anticoagulants. Therefore, the EEC 2012 guidelines say that when oral anticoagulation is recommended, one of non-VKA antagonists should be considered rather than warfarin. That is a class 2A indication. It's a strong indication, should be considered, but whether now we have enough evidence to actually change this to class 1 indication, that obviously is to see. The task force for the EEC guidelines has been set up, and the results are expected probably in 2016. Now, obviously, a lot of update is needed with regard to procedures performed on new oral anticoagulants. So we all know that there was a number of sub-analyses from the randomized clinical trials RELY, ROCKET, Aristotle, and ENGAGE-AF, showing that, in fact, performing cardioversion in patients treated with NOAS was as safe and effective as performing cardioversion on warfarin. The randomized clinical trial XVERT, the results of which were presented at the EEC last September, stratified 1,500 patients into receiving open-label rivaroxaban versus dose-adjusted warfarin, and the patients were further stratified, or before this randomization, were stratified into two groups: those who were undergoing standard cardioversion, standard anticoagulation for 3-4 weeks prior to cardioversion, and those who would undergo TE. And an interesting result from the so-called delay or standard arm in the XVERT trial showed that with rivaroxaban, all but one patient were cardioverted as planned. That's shown on the right side of this slide. Whereas 1/3 of patients on warfarin only 1/3 of patients on warfarin were cardioverted as planned due to problems with achieving the target TTR. So the ACC AHA HRS guidelines released in March 2014, perhaps not even having the results of XVERT, anticipated these results, and they recommended using dabigatran, rivaroxaban, and apixaban for cardioversion as a class 2A recommendation, and at that time as a level of evidence C. Perhaps now this has to be upgraded, since a number of studies have been published and some studies are ongoing. Now, ablation performed on oral anticoagulants. There was a meta-analysis of observational non-randomized studies. Only one was randomized in this particular set, of performing ablation on dabigatran. There was no signal that performing ablation on dabigatran would incur more complications in terms of bleeding or thromboembolic events compared with uninterrupted mostly or even uninterrupted warfarin. Similar results have been obtained with rivaroxaban, and I elected to show you the JUST study from Dr. Lucky Reddy. A number of patients was 300. And you can see that, again, there was no signal that rivaroxaban may be harmful in these patients. So we have the 2012 HRS ERA guidelines on anticoagulation periablation, and it is recommended only that the patient can be ablated safely on uninterrupted warfarin, and this is practiced in the majority of hospitals worldwide. And only after ablation can a DTR or factor Xa inhibitor be prescribed. So obviously this needs update and guidance how to manage a growing number of patients that will have ablation on a new anticoagulant. Now, turning to some drug treatment. Now, when I designed this chart in 2008, it was much more colorful and cheerful. And over time, so many agents dropped from this list for futility or side effects or lack of efficacy, and everything which is in gray means that these drugs are now no longer in the list of investigational products for atrial fibrillation. Nevertheless, some of these did make to the market, and I want to give you the last evidence about the dronedarone. The drug received bad publicity after the PALAS study because the study was designed probably in the wrong setting of patients. The PALAS study showed increased all-cause mortality and various other hard endpoints in the dronedarone arm compared with placebo. Based on this analysis from the large Department of Defense database in the United States, in patients who are suitable for treatment with dronedarone, it's clear that dronedarone is not associated with increased cardiovascular hospitalization or death or all-cause mortality compared with traditional antiarrhythmic agents. Now, there are obviously some new developments that perhaps may potentially enter, if not next, but the update of the next guidelines. And I'd like to bring your attention to a drug, ranolazine, which is licensed for treatment of stable angina. Now, this drug has also shown some antiarrhythmic potential. In this pilot study, adding oral ranolazine on top of intravenous amiodarone for cardioversion of recent onset atrial fibrillation has demonstrated a superiority of a combination therapy versus amiodarone alone. So the blue line, that's patients, the number of patients that cardioverted within the first 24 hours on the combination therapy. This has been tested in a range of trials. One of these, the Raffaello trial, was presented at the HRS last May, and it showed, the study was small, it couldn't achieve the endpoint with a statistical significance, but it showed that ranolazine at higher doses, 5 milligram twice, 500 milligram twice a day, or 750 milligram twice a day, was associated with fewer recurrence of atrial fibrillation post-electrical cardioversion. Ranolazine was tested in combination with low-dose dronedarone. In fact, there were 2 doses of dronedarone in this trial called Harmony. It was also presented at HRS in May. And you can clearly see the reduction in atrial fibrillation burden detected in patients who were implanted with pacemakers. So all atrial fibrillation episodes were picked up and analyzed. So compared with baseline, the clear reduction was seen with a combination of ranolazine with dronedarone, the last 2 charts. Now, quickly moving to atrial fibrillation ablation. I think that now we are moving from technological advances, from targeting specific symptomatic patient populations with paroxysmal atrial fibrillation to wide applicability of this therapy. And of course, when the indications for therapy are expanding, it's very important to know whether this therapy will not only affect the rhythm control, but also will it help survival patients in terms of all-cause mortality and survival without disability or comorbidity. A number of trials, the Castle, Cabana, and East, are underway, and they will address the hard points of all-cause mortality, heart failure hospitalizations, cardiovascular hospitalizations in this set of patients. Now, another important point that perhaps will have to be incorporated in the guidelines is that our management of atrial fibrillation patients is indeed a little bit chaotic. It varies from department to department. It depends which setting the patient is being seen, whether the patient has been referred to tertiary center. And very often, therapy, which is sometimes life-saving therapy, such as anticoagulation, is delayed due to poor structure of atrial fibrillation management. And in this particular trial, some 700 patients were randomized into 2 arms. One received the usual care, and another was followed up in the specialist nurse clinic. So it means better patient education, assessment of patients' risk and side effects of treatment, earlier prescription of medication. You can see that in usual care, the composite of cardiovascular hospitalizations or death was 20%, compared with the nurse-led, where the composite endpoint was 14%. This was an equivalent of a 35% reduction in an endpoint just due to better approach to atrial fibrillation management. And this was true not only for hospitalizations, which were reduced by 34%. This was true also for cardiovascular death, the risk of which was reduced by almost 2/3. So in conclusion, I think that new guidelines should incorporate the following knowledge. First of all, it's better screening of patients, systematic screening of high-risk patients, and refining of risk stratification schemes may lead to better patient-tailored therapy and lower risk of complications. With the development of NOACs, which are no longer new, they are non-vitamin K antagonists, that's what the acronym NOACs should stand for. There is a potential paradigm shift to replacing warfarin in wider patient population. The future of antiarrhythmic therapy in atrial fibrillation is pretty much far from certain, but there are some promising developments, and hopefully the companies will come with better suggestions. In terms of ablation, we are focusing on hard endpoints, as I highlighted, and better structured early management of atrial fibrillation is likely to bring about more benefit from even existing therapies compared with the usual care. Thank you for your attention.